Good morning, and thank you for watching this video tutorial on our approach to the HSS NCD country assessments. My name is Melita Jakob. I'm a senior health economist in the WHO Regional Office for Europe. And in this video, I will walk you over the country assessment guide we developed as a common approach to the country assessments. The country assessment guide provides a common approach for all the country assessment teams, but it is not a straitjacket. And in all the country assessments, we encourage innovation and new approaches and complementing the core material with the guide with appropriate and contextualized additional material as needed. The country assessments rest on three pillars. First, we ask how well the country has been doing on NCD outcomes in terms of mortality for cardiovascular disease, cancer, lung diseases, so on and so forth. Then we attempt to link this to the coverage level of core NCD services. These include both population interventions, tobacco, alcohol, nutrition, physical exercise, and individual services for cardiovascular disease, diabetes, lung diseases, as well as cancer. We attempt to link the pattern of NCD outcomes to the pattern of NCD core services and see whether low coverage or limited coverage with core NCD services can be behind the NCD outcome trends in the past. We also carry out a forward-looking analysis of what is the potential of the country to achieve the 25 by 25 targets. That is a 25% reduction in NCD mortality by 2025, and to what extent that requires scaling up of core population interventions and individual services. After these two first pillars of the analysis, we move on to looking at the health system itself. These core NCD services we're talking about, they are not complex. Their effectiveness and cost effectiveness has been well known. So we ask, why is it that the health system we're analyzing cannot deliver these at scale? What might be some of the systemic barriers or challenges that prevent at-scale delivery of these core NCD interventions and services? However, we don't only look at challenges, we also try to assess opportunities that the country has or has already taken advantage of to scale up coverage and to accelerate outcomes for NCDs. On the next slide, you can see the outline of the country assessment reports. These are standard across country assessments, and they're comprised of 5 sections. Section 1 documents an analysis of NCD outcomes. Section 2 looks at the pattern of core NCD interventions and services in the country. Section 3 provides an analysis of health system challenges and opportunities. Section 4 documents selected innovations and good policies, and Section 5 ends the report with policy recommendations. For the rest of the presentation, I will go through each of these 5 sections and provide some pointers and some notes on methodology on how to carry out the assessment and the writing for the report. So let's start with the NCD outcomes. We use the global indicators to which all member states of the WHO European region have committed to, but we modify the formulation of the indicators for data availability in Euro. Typically, we use the Health for All database as the data source because this provides standardized death rates, which makes the data comparable across countries. But we also vet these indicators against national statistics, and we use national statistics as well as survey data to complement the WHO Health for All database. The indicators are typically formulated as standardized death rates for population age 0 to 24 per 100,000, and this captures really the premature mortality or the premature disease burden for cardiovascular disease, diabetes, cancer, chronic respiratory disease. The focus of the analysis in the first instance is backward looking. We look at a historical time trend in these outcome indicators, but we also aim to compare the country's performance with other countries in the region, in the sub-region, or at similar income levels. The analysis continues with a forward-looking part to see what is the potential in the country to achieve a 25% reduction in NCD mortality by 2025. The last bullet is actually very, very important. We made a big effort to integrate distributional issues throughout the assessment guide. So this means in the NCD outcomes part, in the part on the coverage of core interventions and services throughout the health system barriers, we seek to look at not only averages and how the average person in the country fares, but also to look at distributional issues, equity concerns, and marginalized or vulnerable populations. So we try to do this through thinking about geographics, gender, income-related differences, but any other potential socioeconomic differences that affect NCDs. So it is very important already at the outcome phase to try to dig out as much data as possible on mortality rates across geographics, across gender, income-related, or related to any other factors. This tends to be very challenging at the outcome levels, especially because the Health for All database only provides gender-related inequalities, but it does not break down the mortality rate across geographics and income or other factors. So this is where the use of national data or some already conducted national analysis that can be cited becomes very useful. Typically in this work, we don't have a chance to carry out original research around these areas, but this is why it becomes very important to explore what's already been done in the country and use and cite extensively already published or already carried out equity-related analysis. Last point on NCD outcomes. In the 2014 country assessments, we would like to put a spotlight on men. In the country assessments of last years, we noted and documented the patterns that, first of all, premature male mortality from cardiovascular disease is much higher among men than among women. Second, there is a much greater prevalence of risk factors for NCDs among men than among women, and a significantly lower utilization of primary health care controlling for fertility. In 2014, we would like to continue documenting this gender gap related to outcomes, risk factors, as well as utilization of core individual services. But we would like to go beyond this, and we would like to explore more why these patterns persist. Of course, in the literature, there are a number of hypotheses about this gender gap. For example, one of the hypotheses is that the psychosocial stress of transition and the new economic reality affects men to a greater extent than women, and this also appears in health outcomes and mortality rates. Another outcome could be that cultural factors such as gender roles and the definition of being a man versus a woman predisposes people to certain frequency of healthcare utilization. Or, for example, bonding among men requires a much greater propensity to consume alcohol, if you will. A third hypothesis relates to intra-household resource allocation and how this affects healthcare seeking. And a fourth hypothesis relates to the patient-doctor gender matching, which means that since most primary healthcare doctors are women, men may prefer to go to specialists and choose male practitioners. These are hypotheses and have not been very much explored, or not all of them have been explored. We would like to use the 2014 country assessments to explore these issues deeper. So this would mean that there could be some focus groups conducted prior to the country assessments or after the country assessments, and the analysis of the results could be channeled to the assessment report. But other ways, like doing small-scale surveys, could also be a good idea. Let's now move on to the second section of the report, which is the coverage of core interventions and services. We know a lot what works to reduce NCD mortality, and what works is full delivery of so-called core interventions and core services. Let me now give you a definition of what we mean by core interventions and services. These services and interventions are evidence-based, have a solid evidence that they lead to a reduction in mortality. Second, they're high impact. Third, they're cost-effective. And fourth, they're feasible to implement in a large variety of healthcare settings or health settings or system settings, not only in high-income countries, but also in low and middle-income countries. For terminology, for clarity on terminology, we have divided these core interventions and services into population interventions and individual services. And let me expand on them now in the next two slides. The core population interventions for NCDs relate to the trinity of anti-smoking interventions, interventions to prevent harmful alcohol use, and interventions to improve diet and physical activity. On this slide, you can see the interventions specified in greater detail, such as raising tobacco taxes, putting in place smoke-free environments, warnings about the dangers of tobacco and smoke, so on. These interventions and services come from the global and European action plans for the prevention and control of non-communicable diseases. You can see a little bit of a more expanded list in the guide. It didn't fit on the slide because we have added some interventions and services to allow a little bit of a more comprehensive assessment. And you can also see on the slide how these interventions correspond to the voluntary global targets adopted over the last 2 years. On the next slide, you can see the same for individual health services, the core services for individual services. And you can see that these are grouped around cardiovascular disease and diabetes jointly, then just diabetes and cancer. For both population interventions and individual services, we developed a scorecard approach to assess coverage. This scorecard approach uses a traffic light rating and assesses whether the coverage of that intervention or service is extensive, moderate, or limited. We developed exact criteria, and this can be found in Annex 2 and 3 of the guide, Annex 2 for population interventions and Annex 3 for individual services. This can really help the country assessment teams to come up with a consensus-based assessment of whether coverage or delivery of these interventions and services is extensive, moderate, or limited. Now let me show you on the next slide an example how this looks. You can see here, for example, that the first two interventions on the population side are raising tobacco taxes and smoke-free environments. We would consider coverage of the first intervention limited if the total tobacco tax is less than 25% of retail price. We would consider it moderate if the tax is between 25 and 75% of the retail price. And we consider it extensive coverage if the tax is greater than 75% of the retail price. Filling out the scorecard is more straightforward for population interventions than for individual services. If you look at the first core individual service, it is risk stratification in primary healthcare for cardiovascular diseases. This requires looking at the percentage of patients for whom the 10-year cardiovascular disease risk is documented in patient records. In most countries we have done this assessment. This data was not available centrally, neither in health insurance fund databases nor in centralized medical information systems. So the approach we took is to have facility visits with a joint national and international team that comprised of clinicians as well as health system experts. And this team looked at clinical records as well as carried out some interviews with the doctors and came to a consensus-based assessment. This is not an ideal method, but it is a good approximation in those countries where this data is not available systematically. Now, returning to the previous slide, a final point about the scorecard is that using these terms, limited, moderate, and extensive coverage, may be sensitive in certain contexts and may polarize the discussion and lead to arguments about the details, whether the rating is limited versus moderate, rather than really the substance of the issues. If such sensitivities are encountered, either in the pre-discussions with the Ministry of Health and other stakeholders or during the mission, it might be wise to abandon the traffic light rating and to focus on the substance of the discussion rather than arguing about whether the rating should be limited or moderate. In the majority of the countries, we did not find a problem using a traffic light rating, and in many cases the countries themselves had a very open performance-related attitude or performance-oriented attitude to the discussion, where they wanted to take a very hard look at how their system performs vis-a-vis delivering and covering these core interventions and services. And they gave themselves very tough ratings. So the country assessments should be flexible in this sense, to follow the guide in terms of looking through the core interventions and services, but if it is necessary, then abandoning the rating aspect. After the analysis of outcomes and coverage of core interventions and services, we turn to exploring health system challenges or health system barriers that stand in the way of scaling up coverage and achieving good NCD outcomes, or conversely exploring health system opportunities. With Professor Mark Roberts from the Harvard School of Public Health, we have developed 15 health system features that could be viewed either as challenges or opportunities to respond to NCDs. These 15 challenges and opportunities vary a great deal from each other. Some of them are national level issues, some of them are health system issues, and some of them go down to the individual provider or even to the patient. Why we chose these categories rather than using a well-known health system framework, such as the WHO health system framework with the function or the building blocks, is because when we were speaking to policymakers about health system challenges related to NCDs, these were the terms that they were using themselves. So these 15 challenges and opportunities mapped the natural language, in our view, that policymakers use to describe the challenges they're faced with when making better policies. Of course, each of these could be mapped to a health system function or to the building blocks framework, but we decided not to do that, to make sure that our assessments are easily channeled and translated into a language that policymakers like using, even if that means that it loses some theoretical or conceptual elegance. Each of these health system challenges and opportunities are described in the background paper that was authored by Professor Mark Roberts and Marianne Stevenson, and it's available for the country teams. And in the country assessment guide, we have developed a set of questions, about 10 questions for each of the health system challenges and opportunities that the country assessment teams should ask and answer in the process of the analysis. So the assessment teams go through each of the 15 health system challenges and opportunities. The different challenges and opportunities are assigned to different experts, both international and local, and they develop a good comprehensive understanding on the nature of this health system feature, this health system challenge, based on the background paper and based on the questions in the guide. They gather information, they conduct interviews and meetings, and come up with the assessment about how that health system feature works in the particular country. Then the real challenge becomes to link these health system challenges and opportunities back to the coverage of core interventions and services. This is what's going to make the report specific to NCDs, and this is what's going to allow us to come up with more specific assessments than we had done previously. Now, we have developed a potential way of doing it. In the guide, we provide a worksheet to link closely the core interventions and services with the 15 health system challenges. In Annex 4, you can see this worksheet for population interventions, and in Annex 5, you can see the worksheet for individual services. On the next slide, I am also showing you a little excerpt from the Kyrgyz country assessment on how this table looks like, and this will allow me to explain a little bit more in detail how this assessment was carried out. You can see vertically what's listed in this table or in this worksheet is the core interventions and services, and here I am showing you the first two core services for CVD and diabetes: risk stratification in primary healthcare, effective detection and management of hypertension. Horizontally across the page, you can see each of the 15 health system challenges and opportunities. In the Kyrgyz country assessment, the team gave a limited rating to the core service of risk stratification in primary healthcare because less than 30% of patients above 40 have their 10-year comprehensive cardiovascular disease risk systematically documented in their primary care patient records. Then the team went on to ask which of the 15 health system features have led to this result, that after 15 years of primary healthcare reform, we still have very poor coverage of comprehensive risk stratification in primary healthcare. And they rated each of the 15 health system challenges either as a minor challenge, a moderate challenge, a major challenge, or a major persistent challenge. In page 30 of the guide, we give a definition or some guidance on how to interpret each of these categories. So this type of analysis is carried out for all of the population interventions and individual services. And I'm not listing the other ones here, but you can see that then there is, at the end, there is a total score in the last line that shows you which of the health system barriers is the most salient for cardiovascular disease and diabetes. So in the Kyrgyz assessment, human resources, financial incentives, and management were the top 3 health system challenges that explain the limited coverage of core CVD and diabetes services. As you're listening to my presentation of this worksheet, you may be wondering if this is a helpful approach or a bit too detailed. Some of the teams actually found this approach helpful. They used it to guide the team discussions, the discussion between the national and international counterparts, and they also found it helpful to prioritize across the 15 health system challenges and opportunities. Other teams felt that it was a little bit unnecessarily too detailed and that the priorities fall out automatically anyways from the discussions without having to put a number to it or fill out this worksheet. Which approach you choose is up to you. It's up to the decision of the team. Both can work. If you use the worksheet, this bottom-up approach, then the challenge is how to synthesize it that the reader does not get lost in the details. But if you use the other approach, the top-down approach, to let the priorities emerge based on consensus, then the challenge becomes how you convince your reader that those are indeed the challenges, the most important challenges, and not others. So this requires a team-based, consensus-based decision, and there are examples for both approaches in the previous 5 country assessments. Let's move to section 4 of the report, which documents innovations and good practices in the country related to NCDs. This is a very exciting part of the country assessments because we seek not only to establish some of the challenges and problems and areas of limited coverage, but also to tap into some of the innovations and good practices that have been done at the country level, document them so that other countries can also follow these, understand these examples and follow these examples. So we encourage the country teams to describe in detail 2, maximum 3 innovations and good practices that have helped the country in question to overcome some of the health system challenges already. Innovations and good practices should be selected jointly by the national and the international team. In the report, they should be described in detail on what was done, how it was done, what was the time frame, what were the implementation modalities, so on and so forth, so that if someone is interested in implementing such kind of an approach, they could get enough information about how it was done. Ideally, we would also like to document the impact of this innovation on behavior of physicians or behavior of patients, and if it's possible, on outcomes as well. Of course, this is a major challenge and we have not been able to live up to this in almost any of the previous country assessments, but this is a noble goal to strive for. This is very important because we have to justify why we selected this as an innovation or a good practice, and if we don't have any impact on behavior and outcomes, then it will be very challenging to do so. In most assessments, it would be good to note enabling and hindering factors of implementation to bring a little bit of the reality into the picture. We suggest that the country teams identify candidates for innovations and good practices prior to the mission. So going into the mission with an idea of 4, 5 or 6 health system interventions in the past 5-10 years that could be considered innovations and good practices, and during the mission make a consensus-based agreement on which one they will focus on. And then you will need to assign that to somebody on the team to go behind that, gather the information and the evidence to be able to describe it. On the next slide, I wanted to show you an example. Quite a few of the innovations in the previous 5 country assessments related to how public health and primary care join forces. In 3 out of the 5 countries, we found that the countries were working on amplifying the strength of primary health care by joining forces with public health structures. So this would, for example, be outreach activities to the population to proactively seek out asymptomatic cases, or practice health education and motivation in a group and individualized setting. The examples include the opening of health promotion offices in outpatient clinics in Hungary, 1,200 village health committees established in Kyrgyzstan linked to primary healthcare facilities in rural areas, and in Turkey, governing primary healthcare out of the Public Health Directorate allowed them to combine forces with outreach activities as well as the lab system. And in all of these cases, these approaches have been very helpful and strengthened the resources of primary healthcare. Then we arrive to the last section of the report, which is policy recommendations. Policy recommendations should focus on removing the identified health system barriers with a greater focus on those that were found to be more salient or more important. They should be pragmatic and actionable based on international evidence, contextualized to the reality of the country, sensitive to time frame and sequencing, and if possible, incorporate what-if scenarios with enabling and constraining factors. And finally, I would like to end my presentation on a few suggestions or notes on methods. The guide, of course, is the core of the work, but some information and data may be difficult to find, especially in the context of a 5-day mission. And country contextualization may require the teams to go beyond the guide, and we encourage innovative additional approaches that are not described in the guide. So, for example, to commission operational research, focus group discussions, additional survey data analysis. This can be done prior to the mission or after the mission, because the report writing will take a little bit of time. So there is a few months between the mission and the finalization of the report to commission additional work, not large scale, but relatively small scale, that can provide some additional helpful information and supporting evidence. So to give you some examples, in Kyrgyzstan we carried out a small-scale operational research surveying 93 family doctors, 27 specialists and 117 patients. And we added their opinions to the report about primary health care. In Turkey, we made extensive use of already analyzed survey data on health behaviors, social determinants of health and equity. And in addition to this, in Turkey, we also had a 3-day field visit to one of the regions to complement our observations and interviews in the capital city. And the final point for me to make is that when you're writing up the report, we are not aiming for descriptive papers that describe the health system and how it works. We are aiming for analytic and message-oriented reports. So each paragraph of the report should communicate a clear message. The first sentence of the paragraph should summarize this message, and then the rest of the paragraph should provide detail and supporting evidence. We found that this was fairly challenging because often the natural instinct was to provide a lot of background information, but it's better to reference it from health in transition profiles or existing health system descriptions, and only refer to it and keep the report as analytical as possible. Another challenge that became clear to us during the writing phase of the first 5 reports is that these are large reports and it's difficult for the reader to go through it unless there is really good connections between the different sections of the reports. So connecting the outcomes with the core interventions and services, connecting the core interventions and services with the health system challenges, the innovations, and then connecting that very clearly with the policy recommendations. So there should be logical links across the sections of the report throughout, and little summary statements that help the reader go from one section to another. And as I mentioned previously, findings should be as specific to NCDs and core services as possible, rather than generic health system statements. Thank you very much for your attention, and good luck during the assessment mission.